Hey guys, welcome back everyone to the high yield revision of FMGE. We are starting with the cardiology. So in this module, in next 1 hour, we will address three important topics, that is heart failure, cardiomyopathies and arrhythmias. Ischemic heart disease and valvular heart disease are also equally important, but that we will deal through certain MCQs in 1 or 2 days now. Okay, so we will start with heart failure first. What is important from heart failure? We need to know the diagnostic criteria for heart failure, classification of heart failure based on the ejection fraction, and management. When we talk about management, we are stepping into pharmacology, but obviously we need to know very well. Then when it comes to cardiomyopathies, primarily classification, and more important than classification. Yes, there are few MCQ points which we will address. More important than that, there are two: hypertrophic cardiomyopathy and Takotsubo cardiomyopathy. That's what we need to learn. And then arrhythmias. I'm anticipating strongly one question on arrhythmias this time. Last couple of exams there were nothing from the ECG, but arrhythmias might bring one question this time. So that is what we will address. Okay. So we'll start with the heart failure. Essentially, what is heart failure? Heart does two functions. During systole, the ventricles contract and eject the blood. And during diastole, they relax and receive the blood. So if they are not able to contract sufficiently to eject well, or they are not able to relax sufficiently during the diastole to allow the filling well, both of them will be counted as heart failure. So systole goes dysfunctional, systolic heart failure; diastole goes dysfunctional, diastolic heart failure. Now how do we classify the heart failure? The traditional method is to classify it as right heart failure and left heart failure. So whenever right heart fails to work properly, whether it is systolic or diastolic, the final outcome is the pressure inside the right atrium increases and it leads to certain consequences. What are those? Increase in the right atrial pressure leads to rise in the JVP. Then congestion of the livers. Congestion of the liver leads to hepatomegaly. Hepatomegaly running for several years can also lead to cardiac cirrhosis. If the congestion of the liver happens, pressure inside the liver sinusoids is high, eventually that will lead to portal hypertension and that can lead to ascites. Similarly, drainage of the blood from the lower limbs through inferior vena cava into the right atrium will be impaired and that will lead to pedal edema. So that is why classically raised JVP, congestive hepatomegaly and pedal edema are considered as the features of right heart dysfunction. If the left side of the heart fails, whether left ventricle is not able to generate sufficient force of contraction during systole or not able to relax well to receive the blood during diastole, the final outcome is pressure inside the left atrium increases and that leads to congestion of the lungs. So in right heart failure, congestion happens in the liver. In left heart failure, the congestion happens in the lungs. So congestion of the lungs leads to dyspnea or shortness of breath, and there are two subtypes of dyspnea called as PND, paroxysmal nocturnal dyspnea, and orthopnea. Those questions can be asked around this. We will address that. Apart from that, left heart failure can also lead to pedal edema. Here it is not because of the rise in the pressures on the right side of the heart, but it is indeed because of the activation of the renin, angiotensin, aldosterone axis leading to excess production of aldosterone. Aldosterone causes salt and water, increased reabsorption leading to pedal edema, right? And then in patients with left heart failure, there is reduced cardiac output, so that leads to experience of fatigue. Okay, few points about orthopnea and PND. What is PND? PND refers to paroxysmal nocturnal dyspnea. So typically what happens, patients with PND, generally they go to bed, they get into sleep, they don't have shortness of breath as of now. 90 to 120 minutes after going to sleep, patient starts experiencing shortness of breath, and the shortness of breath is severe enough to wake them up from the sleep. Once they wake up from the sleep, they sit quietly for 30 to 45 minutes. During that period, the shortness of breath slowly recedes and then they go back to sleep, and this cycle goes on repeating. In orthopnea, as soon as you make them flat, right, as soon as they are flat on the bed, they feel short of breath. As soon as they are upright, the relief is immediate. Okay, so orthopnea is shortness of breath on lying down and relief on upright posture, both happening immediately or spontaneously. The main mechanism behind orthopnea is the increase in the venous return on lying down, because during upright posture, gravity makes more blood to pool in the lower limb. But when we lie down, the gravity impact is eliminated and all that blood from the lower limb through the veins reaches the right side of the heart. From the right side of the heart, it reaches the lungs and increases the congestion of the lungs. So if the lungs get more congested, obviously shortness of breath will increase. But as soon as I take an upright posture, gravity takes the blood to the lower limbs and thus the venous return drops and the lung congestion reduces and the shortness of breath disappears. That is one important component. The second important component responsible for orthopnea is the diaphragm. So when we lie down, diaphragm slightly ascends up in the thorax and there is less space available for the lungs to expand. That also contributes to orthopnea. Right. So point to note about orthopnea is that orthopnea is not specific for left heart failure. It can also be seen in conditions which can push the diaphragm up, like massive ascites, then diaphragmatic palsy, and sometimes even after heavy meals. If you take too heavy meal, many of us feel short of breath. It is because of that diaphragm being pushed up. On the other hand, PND, the main mechanism for PND is that when these patients go to sleep, right, there is a patient with heart failure, so they might have edema. All that edema fluid slowly comes to the circulation and reaches the heart. From the heart goes to the lungs. So slowly it starts accumulating in the lungs. Obviously this edema is not going to disappear immediately on lying down and then get into the lungs. The blood pooled in the veins will immediately go to the heart and go to the lungs. That is why orthopnea, the shortness of breath, is immediate on lying down. But in PND, it is the edema fluid that is slowly coming to circulation. So for that to happen, it takes several hours. Second, during sleep, we go into this rapid eye movement phase of sleep where there is activation of sympathetic nervous system. Activation of sympathetic nervous system in a failed heart leads to a lot of consequences. What is that? If we activate the sympathetic nervous system, heart rate increases, its myocardial oxygen demand increases. It is a failing heart. It may not get that demand supplied. So it worsens the heart failure. Second, if the heart rate increases, the diaphragm goes on progressively, not the diaphragm, the diastole goes on progressively becoming shorter and shorter. It is the diastole during which we fill the ventricles. So if the diastole becomes shorter, ventricular filling reduces. If I am not filling the ventricles well, I will not be able to eject much from the ventricle, because from where the ventricle will eject the blood, whatever I fill into the ventricle, that is what it is going to eject. If less filling, less ejection, so the cardiac output drops. Right. So why that is happening? Because during the rapid eye movement phase of sleep, the activation of sympathetic nervous system happens. That is because of the dreaming. So we get into dreams which activates our sympathetic nervous system. Right. So that is why it takes around 90 to 120 minutes for the shortness of breath to appear in case of PND. And once the patient wakes up because of shortness of breath, the sympathetic nervous system is not going to cool off immediately, and whatever edema fluid that has now come to lungs will not go to the lower limbs immediately. It takes some time. That is why the recovery takes 30 to 45 minutes. So what is the difference between orthopnea and PND? Orthopnea, shortness of breath immediately on lying down, improvement immediately on upright posture. PND, shortness of breath 90 to 120 minutes after sleeping, and once the patient wakes up and takes an upright posture, relief 30 to 45 minutes later. So neither onset nor relief is immediate in case of PND. In orthopnea, both are immediate. Orthopnea is not specific for the left heart failure. PND is the most specific. PND is the most specific clinical feature of the left heart failure. Clear? Okay. Now, what are the causes for heart failure? The causes for heart failure again can be studied as left and right heart failure. Okay. And the most common heart failure is left heart failure. Left heart failure is overall more common than the right heart failure. And the most common cause for left heart failure, and thus the most common cause overall for the heart failure, is hypertension. So when hypertension happens, left ventricle develops hypertrophy. A hypertrophic left ventricle cavity becomes smaller, so diastolic filling gets impaired, and that is what heart failure is, right? If we are not able to fill well or not able to eject well, that is heart failure. The second most common cause for heart failure is ischemic heart disease. You have myocardium which is not getting sufficient blood supply, so in that case it cannot contract well, so ejection gets impaired. That is systolic heart failure, right? Apart from that, all our valvular heart diseases can cause heart failure, and dilated cardiomyopathy can also cause left heart failure. The right heart failure, they will ask you only one MCQ. What is the most common cause for right heart failure? The most common cause for right heart failure is left heart failure. So when left heart fails, left atrial pressure increases, right? Pulmonary venous pressure increases, congestion in the lungs happens. Eventually that leads to pulmonary artery pressure going up, then right ventricle developing hypertrophy, and that is where the right side of the heart starts failing, right? Apart from that, yes, conditions like pulmonary hypertension, pulmonary stenosis, ischemic heart disease, restrictive cardiomyopathy, pulmonary embolism, they can also cause right heart failure. But the most common cause is left heart failure, and the second most common cause is the COPD. So COPD leads to right heart failure. We call that condition as cor pulmonale. Cor pulmonale. Okay. Now, how do we diagnose heart failure? In the past, we had a criteria called as Framingham criteria. So when any patient presented with symptoms of heart failure, we used to give relative weightage to individual symptoms. There were major, minor criteria to decide whether patient has got heart failure or not. Today, we do not follow that Framingham criteria. So you have to only remember the name. You don't need to spend your time on Framingham's criteria. So what is the current criteria? The current criteria is AC, American College of Cardiology, and American Heart Association criteria endorsed by WHO. So what it says is any patient who has signs and symptoms of heart failure, means raised JVP, hepatomegaly, ascites, pedal edema, orthopnea, P&D, right, shortness of breath on exertion. Those are the signs and symptoms of heart failure. In patients with these signs and symptoms, you have to prove that these symptoms are because of cardiac dysfunction. And we can prove that cardiac dysfunction by looking at the biomarkers. There are two kinds of cardiac biomarkers. One which elevates when there is a myocardial injury, like your CKMB, troponins, right, heart type fatty acid binding protein, ischemia modified albumin. They are generally elevated when myocardium is injured. They are useful for diagnosis of MI. But for heart failure, we need those biomarkers which will be secreted when the ventricles or the atria are stretched. So basically those markers are your natriuretic peptides like ANP, BNP. So any patient with signs and symptoms of heart failure with raised BNP or a precursor molecule of this BNP called as N-terminal proBNP. So if these levels are elevated in presence of signs and symptoms of heart failure, the diagnosis of heart failure is done. You don't need to apply any Framingham criteria or anything. Here specifically, I want you to remember these numbers. Generally, I am a person who is against remembering numbers because there are so many numbers in medicine, you can't remember everything. But these two numbers I want you to remember. BNP more than 35 picograms per ml and NT-proBNP more than 125 picograms per ml means you have heart failure. Once we have diagnosed the heart failure based on signs and symptoms and the positive biomarkers, for further management, we need to know which type of heart failure it is. I'm not talking about right heart failure or left heart failure. Currently followed classification criteria primarily focuses on ejection fraction. Okay. So what is ejection fraction? Ejection fraction is a ratio of stroke volume and left ventricular end diastolic volume if it is left ventricular ejection fraction, right ventricular end diastolic volume, and the right ventricular stroke volume if it is right ventricular ejection fraction. So EF is stroke volume divided by end diastolic volume. So basically what does that mean? At the end of diastole, if this is my left atrium and this is my left ventricle, at the end of diastole, how much blood is there in the ventricle? That is end diastolic volume, right? Out of this blood, right? Let me say this end diastolic volume is 500 ml. Out of this, how much of it gets ejected into the aorta in one contraction? That is what is our stroke volume, right? Amount of blood ejected out of ventricle during one systole or one contraction. That is our stroke volume. So if I eject 300 ml out of this 500 ml that was there at the end of diastole in the ventricle, this 300 ml becomes stroke volume. Now how do we calculate the ejection fraction? Stroke volume divided by 500, and because we express it in percentage, we have to multiply it with 100. So in this case, it becomes 300 by 500, which is 60. Right, 300 by 500 is 6 into 100, it becomes 300 by 500 is 0.6 into 100, it becomes 60. So 60% would be the ejection fraction for this example that I gave you. Is that normal? Yes, the normal ejection fraction is 60 to 70%. So at the end of diastole, whatever quantity of blood is there in the left ventricle, that is end diastolic volume, which is also called as preload, right? It is also called as preload. Out of which how much percentage blood gets ejected as stroke volume, that is ejection fraction. If I eject 60% of it, ejection fraction is 60%. If I eject 70% of it, ejection fraction is 70%. Okay, so based on the ejection fraction, the heart failure is categorized into three groups: heart failure with preserved ejection fraction, heart failure with reduced ejection fraction, and heart failure with mid-range. So when you have a patient with heart failure and you calculate the ejection fraction and it is less than 40%, we call it as heart failure with reduced ejection fraction. Normally 60 to 70%. So if it is 50 plus, close to normal, then we will call it as heart failure with preserved ejection fraction. Ejection fraction affected nahi hai. And if it is between 41 to 50%, then we will call it as heart failure with mid-range ejection fraction. Okay. Why this is important? Because if the ejection fraction is low, it mostly means that ventricle's ability to contract is less. So it is ejecting less percentage of blood given to it. Right? So it indicates that there is a systolic heart failure. If ejection fraction is close to normal or normal and you still have heart failure, that means it is not the ability of the ventricle to contract. It is the ability of ventricle to receive the blood which is impaired. So it indicates that you have the diastolic heart failure. Again, why this is important? Because before the advent of echo, we were not diagnosing these cases as heart failure. So whatever we know today about heart failure, its management, impact on mortality, all that comes from our experience with heart failure with reduced ejection fraction. So all of our pharmacology and pathophysiology discussion is going to focus on this: systolic heart failure or heart failure with reduced ejection fraction. Okay. So basically what happens in heart failure? Whenever we have a heart failure, the final outcome is there is decreased cardiac output. Why there is decreased cardiac output? Either your ventricle is not able to contract well, stroke volume is reduced, cardiac output is nothing but stroke volume into heart rate. So if the stroke volume is reduced, cardiac output comes down. Or your ventricle is able to contract well, but it is not able to fill well. So in that case, the end diastolic volume is reduced, less filling, less ejection. So ultimately what happens? Cardiac output gets reduced. So when there is decrease in cardiac output, the blood pressure depends on cardiac output. There are other factors, but cardiac output is an important determinant. So if the cardiac output is low, the blood pressure will decrease. So when blood pressure decreases, heart failure leads to drop in blood pressure. The corrective mechanisms will get kicked in. What are those corrective mechanisms? One of the corrective mechanism is the renin-angiotensin-aldosterone system. Renin-angiotensin-aldosterone system. So this renin-angiotensin-aldosterone will have production of angiotensin 2, which will cause vasoconstriction. If the blood vessels are constricted, it will increase the blood pressure. So this can help you have a normal BP despite having heart failure. Similarly, this RAS has aldosterone, which increases the sodium and water reabsorption, increases the blood volume. Increased blood volume can correct your BP. But despite correcting the BP, we end up harming the heart more by activating this RAS. Why? Because if the blood vessels constrict, now the heart has to pump the blood through these constricted blood vessels. So heart needs to do more work. Right? If the blood vessels are dilated, easy to push the blood into those dilated blood vessels. But if they are constricted, it needs to do more work. This resistance that the constricted blood vessels offer is what we call as afterload, and this afterload is increased once there is vasoconstriction. Similarly, if the blood volume increases, then at any given point of time, the left ventricle will be receiving more than usual amount of blood. So that means end diastolic volume increase. This end diastolic volume is also called as preload. That is also increased. So when we increase the burden on the heart, right, by increasing afterload and preload, it will worsen the heart failure. Okay. Apart from that, there is one more system which is activated because of the decreased blood pressure, and that is the sympathetic nervous system. What sympathetic nervous system will do? This will also cause vasoconstriction. So indirectly, sympathetic nervous system is also contributing to worsening of the heart failure. So when it comes to treatment of heart failure, we need to block this RAS because this is worsening the heart failure. Similarly, we need to block the sympathetic nervous system. Right? But there is also another compensatory change that happens in heart failure, that is when the ventricles are not able to contract well or relax well, right? The pressures inside the ventricles as well as the atria starts rising. That's why we had this orthopnea, PND and all, right? That's why we had raised JVP, hepatomegaly and all, because the pressures inside the cardiac chambers is increasing. Whenever cardiac chambers get stretched because of the pressure, they release the natriuretic peptides like ANP and BNP. What natriuretic peptides do? They do exactly opposite of what aldosterone does. They increase the sodium excretion and water excretion. So by increasing sodium and water excretion, they decrease the blood volume and thus they decrease the preload. So they unburden the heart. So when it comes to treatment of heart failure, we need to block sympathetic nervous system and RAS, and we need to support this ANP, BNP, right? So how can we block the RAS? We can block the angiotensin 2 production by giving the AC inhibitors, or we can directly block the angiotensin 2 receptors by giving the ARBs. How can we block the aldosterone? By giving the drugs mineralocorticoid receptor antagonist like spironolactone. Spironolactone can be used, right? How can I block the sympathetic nervous system? By giving the beta blockers. That is why we use beta blockers, AC inhibitors or ARBs and spironolactone for the treatment of heart failure. But when it comes to this ANP, BNP, how can I enhance its activity? By blocking its degradation. So once they are produced and released, there is an enzyme called as neprilysin, which converts this ANP, BNP to inactive peptide. So I can block it. The neprilysin inhibitors. Example is sacubitril. Example is sacubitril, right? So this is the pathophysiology. Now, having understood clinical features, diagnosis and the pathophysiology, a quick take on the management. How do we manage a patient with heart failure? Mainly the heart failure with reduced ejection fraction. So for this management generally applies regardless of the severity of heart failure for all patients. What we do is we have to block RAS and sympathetic nervous system, right? So that is why we treat them with AC inhibitors or ARBs plus a beta blocker to block the sympathetic nervous system, and then spironolactone. These three are standard drugs. Last couple of years, we have also started using SGLT2 inhibitors as a standard treatment for patients with heart failure, because SGLT2 inhibitors make you lose glucose in urine, with that we lose water, and because of that they also reduce the preload, and an added benefit of weight loss, which also reduces the burden on the heart, right? So this is our first line medication, AC inhibitor or ARB plus beta blocker plus spironolactone plus SGLT2 inhibitor. SGLT2 inhibitors end with gliflozin, right? Empagliflozin, dapagliflozin, gliflozins. That is the first line management. 4 drugs. If these 4 drugs fail to achieve the improvement or symptom control, then this 4 drug treatment combination is what we call a standard treatment. If it fails, then we have explored all this, right? RAS is blocked, sympathetic nervous system is blocked. What is unexplored now? The ANP, BNP pathway, right? So this can be now facilitated by blocking the neprilysin. So if the 4 drug standard treatment fails, then we add neprilysin inhibitor. Currently in pharmacology, you might have studied about various neprilysin inhibitors, but the one that is readily available in India is sacubitril. Sacubitril comes in combination with valsartan. It does not come as a solo drug. And because it comes in combination with valsartan, we have to keep in mind that whenever we want to start an neprilysin inhibitor and I want to give sacubitril, it is coming with valsartan, so I have to take out the pre-existing AC inhibitor or ARBs that the patient is taking, because valsartan is an ARB. So like sacubitril is coming with an ARB. So if the patient is already on AC inhibitor or any other ARB, that needs to be stopped before we introduce the sacubitril valsartan combination. Now all these drugs, AC inhibitors, ARBs, beta blockers, spironolactone, SGLT2 inhibitors and the sacubitril, they all, studies after studies, have shown that they reduce the mortality in patients with heart failure. Why do they reduce the mortality? Because they reduce the burden on the heart. All the mechanisms we discussed are unburdening the heart. But in the past, we used to use drugs called as inotropic agents, which stimulate the heart to contract more vigorously. So with that, they could increase the cardiac output and make the patient's symptoms better, but they are burdening the heart more and they push more towards progressive heart failure and thus increase the mortality. And that is why nowadays we don't use inotropic agents. Most commonly used inotropic agent was digoxin, right? And this is a repeatedly asked MCQ. Which of the following treatment in patients with heart failure is associated with increased mortality? So please remember inotropic agents, more precisely the digoxin, right? So that's a quick take on the heart failure. Just give me 1 second, guys. Okay, so from there, see, the dobutamine is again an inotropic agent. So digoxin not routinely used today for whatever indications we used to use. We used to use digoxin for reducing the heart rate in patients with the atrial fibrillation and certain supraventricular arrhythmias. There also amiodarone and the calcium channel blockers have replaced it, right? But yes, dobutamine we use it, but it is used for acute heart failure, not for the chronic heart failure that we routinely see. We call it as either acute heart failure or acute decompensated heart failure. Okay. Now the next topic we will take up is quickly the hypertension. Hypertension, the diagnostic criteria that is important, initial management and the secondary hypertension and hypertensive emergencies. Okay. So as we know, the best method for recording the blood pressure is 24-hour ambulatory BP recording. If that is not available, then home BP recording. Least preferred method is the office or the outpatient BP recording because of the risk of white coat hypertension and having falsely elevated BP recordings in the hospital, right? The cutoffs for diagnosis of hypertension is not 140/90 standard. It depends on the method used for recording the BP. If you are using 24-hour ambulatory BP recording, then the cutoff is 130/80. If you are using home BP recording, add 5 more, it becomes 135/85. And if it is the OPD recording or hospital recording, then add 5 more, then it becomes 140/90, right? Those are the cutoffs. Okay, now why hypertension needs to be treated? Because hypertension long standing leads to organ damage. We call that today as hypertensive organ damage or hypertension mediated organ damage. In the past, we used to use the term target organ damage or end organ damage. Okay, so what are the organs that can get affected by hypertension? Yes, hypertension leads to increased risk of stroke. So your central nervous system can be affected. Stroke, both ischemic stroke risk is increased and the hemorrhagic stroke risk is increased. Okay, hypertension can cause the cerebral edema resulting in what we call as hypertensive encephalopathy. Okay, all of you are familiar from your ophthalmology that hypertension affects the eyes. We call it as hypertensive retinopathy, right? In hypertension, blood vessels are chronically constricted. So because of that, your left ventricle has to do a lot of work to push the blood into those constricted blood vessels. So left ventricle overworking develops hypertrophy. So LVH is common, and when it develops hypertrophy, cavity becomes smaller, filling the blood into the ventricle becomes difficult, and we develop heart failure. We just learned that the most common cause for left heart failure is hypertension, right? Then hypertension can also affect the kidneys. We call the condition as hypertensive nephropathy. And when we say nephropathy, we have to please remember that diabetes and hypertension are responsible for 70 to 80% of the patients of CKD who require dialysis. Diabetes is the most common cause for CKD, and hypertension is the second most. Diabetes accounts for 2/3 of the patient, and another 20% cases are because of hypertension. That's why almost 80% of the patients who are having CKD and then they are getting regular dialysis or going for kidney transplantation are either because of diabetes, hypertension, or both. Okay, then hypertension also increases the risk of atherosclerosis. Why? Because when blood passes through a constricted blood vessel, it causes endothelial injury, right? Endothelium is the inner lining of the blood vessel, so that gets injured. And endothelial injury, as per Virchow's triad, it is one of the part, right? Virchow's triad has endothelial injury, hypercoagulability, and stasis. So if I go on injuring endothelium, I can trigger formation of clots as well as development of atherosclerosis. Okay, so these are all the outcomes of untreated hypertension. So that means that we need to recognize hypertension and treat, right? How do we treat? Treatment depends on the stage of the hypertension. So how do we stage? The staging of the hypertension is now into two stages, stage 1 and stage 2. What is it based on? It is based on the office BP recording, not the 24-hour ambulatory recording or home recording. That is only for initial diagnosis. After that, we don't follow that. We will primarily stick to the OPD recordings, right? So based on the OPD recording, the patient's BP will be categorized as being either stage 1 or stage 2. All you need to do is understand stage 2. Stage 2. If systolic BP is more than or equal to 160, or diastolic BP is more than or equal to 100, it becomes stage 2. Say, remember, any one of them above this cutoff, either systolic more than 160 or diastolic more than 100, it will be counted as stage 2. If both the values are below this, right, that means systolic 140 to 159 and diastolic 90 to 99, it will be counted as stage 1. Okay, any patient with stage 2 hypertension, like, okay, I have a patient here with systolic BP 170, diastolic 90, that is stage 2, right? I have told you anything, either systolic more than 160 or diastolic more than 100 is stage 2. So this patient we just spoke about is stage 2. Stage 2 patients should be directly started on drugs. Start on the pharmacotherapy immediately. Stage 1 patients, we need not always jump to start the medication, but stage 2 should always be started on medication along with lifestyle modification. What lifestyle modification? We recommend them 30 minutes of aerobic exercises per day, 5 days a week, or in other words, 150 minutes of aerobic activities per week, and salt restriction to less than 4 grams per day, or sodium restriction to less than 2 grams per day. And 2 specific diets are recommended. One is Mediterranean diet and the other one is DASH diet. They can ask you the full form of this DASH diet. DASH diet refers to diet against systemic hypertension. Diet against systemic hypertension. Okay, clear? So stage 2 hypertension, start on drugs and then put them on lifestyle modifications. But if it is stage 1 hypertension, if the patient has stage 1 hypertension and Currently, no evidence of any hypertension mediated organ damage, like retina is fine, right? No left ventricular hypertrophy, no other hypertension mediated organ damage, and no risk factors for the atherosclerotic coronary vascular disease, like the diabetes mellitus, dyslipidemia, obesity. Those risk factors are also not there. No organ damage at this point of time. Such patients, we don't need to jump to start medications. Just put them on the lifestyle modification, put them on salt restriction, DASH diet or Mediterranean diet, and then follow them up. As long as BP remains in the specific control target, you don't need to start the medications in them. Every 3 months, you can follow them up. But if the patient has evidence of hypertension mediated organ damage, so you may be asking many times, I had students who ask me, sir, my dad was diagnosed with hypertension and the cardiologist has asked or a physician has asked for a ECG immediately. Sir, why should we do ECG now? He doesn't have chest pain and all. What cardiologist wants to see there? He wants to see whether there is left ventricular hypertrophy on the ECG, right? What is the criteria used for the diagnosis of left ventricular hypertrophy on the ECG? The criteria is called as Sokolov-Lyon criteria, right? So that's why, like, whenever we diagnose someone as hypertensive, we refer to an ophthalmologist to screen for the retinopathy. We get the creatinine and the urine protein check to see if there is any evidence of nephropathy. So if any of that is present, any evidence of any organ damage, or no evidence of organ damage, but there are risk factors for coronary vascular disease, like patient is obese, or patient also has diabetes mellitus, or patient also has dyslipidemia, hypertriglyceridemia, or LDL cholesterol is elevated. In those cases, we need to start them on pharmacotherapy. So two circumstances, we start them on pharmacotherapy. Stage 2 and stage 1 with hypertension mediated organ damage or the risk factors for atherosclerotic coronary vascular disease. What drugs we will start? So current recommendation is to use a combination treatment, not a single therapy. Combination therapy is preferred over monotherapy. Because if you start with only one drug and then try to achieve the BP, you run the risk of developing side effects because you will require higher doses of the medication. When we give multiple drugs together at small doses, the side effects is minimized and we achieve our target. So combination therapy is preferred over monotherapy, and all those combinations, if it comes in one pill instead of taking multiple separate pills, that enhances the patient's compliance to medication. That is why single pill combination is preferred over polypill. Okay. So what is our target for BP? Because we know that when to start. Stage 2 and stage 1 with hypertension mediated organ damage or the atherosclerotic coronary vascular disease risk factors. We will start. What to start we will learn, but before that we should know what is our target, because starting point may be anything. Patient BP may be 210, 120 or 150, 100, whatever it is. Whatever is the starting point, where we should take it to is important, right? So our target BP is to get the systolic less than 130 and diastolic less than 80. As long as it is not achieved, we need to keep stepping up our treatment. Once we achieve this and sustain the BP in this range, then only we can relax, right? So how do we achieve this target of less than 130/80? First line, we start with a low dose combination of AC inhibitors or ARBs and dihydropyridine calcium channel blockers. AC inhibitors or ARBs plus dihydropyridine calcium channel blockers. Dihydropyridine means those which end with dipin, right? Dipin, amlodipine, nifedipine, nicardipine, right? Those are all dihydropyridine calcium channel blockers. First line, we start with low dose of these, right? Low dose of an AC inhibitor plus a low dose of calcium channel blocker. With that, if the target of less than 130/80 is achieved, well and good. If not, then we escalate to the second line treatment where the same drugs become full dose. If I had started low dose amlodipine and low dose enalapril, I will switch to full dose amlodipine and full dose enalapril. If with that control, good. If not, then we go to the third line. In the third line, we don't stop these medications. Means we'll continue the full dose of AC inhibitor or ARB plus dihydropyridine calcium channel blocker, and we will add a thiazide-like diuretic, for example, chlorthalidone. Okay. There are two kinds of thiazides, the regular thiazides and a thiazide-like class. This thiazide-like class gives you some advantages over the regular thiazides. What is that advantage? The regular thiazides are known to cause hyponatremia. In fact, the most common cause for mild hyponatremia is thiazide diuretics. This thiazide-like is a new class which is less likely to cause hyponatremia and slightly more effective. Chlorothiazide is a classical example for thiazide. Chlorothalidone is a thiazide-like diuretic. Mechanism of action is same. That's why we have called them as thiazide-like. So we start with that. We add it along with the regular combination that we had already started. With that, controlled, good. But if not controlled, then we have reached a stage where we have to classify the patient as having what we call as resistant hypertension. When 3 drugs at full or optimally tolerated doses, out of which one is a diuretic, fails to control the BP to target, that is less than 130/80. We call it as resistant hypertension or refractory hypertension. So whenever we reach this stage, we need to do 2 things. One, we have to add an additional drug to control the BP. At the same time, we have to investigate why we have landed up in this situation, because resistant hypertension is often caused by various other causes. Okay, so first we will look at the drug. The drug that we will add is spironolactone, that is a aldosterone receptor blocker. In fact, if they ask you drug of choice for resistant hypertension, the answer should be spironolactone. Okay, we will start with the spironolactone and then we will investigate the cause for resistant hypertension. So we'll understand a little bit about resistant hypertension. What is resistant hypertension? When BP is not controlled to the target. Currently defined target is less than 130/80 with use of more than or equal to 3 drugs at optimal. When I say optimal, either full dose or the dose that the patient can tolerate. Optimal doses, out of which one is a diuretic. So if you're following the current guideline, we would have reached, by the time we have completed the 3rd line treatment, we have reached the stage of resistant hypertension. Okay. Now, what can cause the resistant hypertension? In India, the most common cause for resistant hypertension is the pseudo-resistant hypertension. Pseudo-resistant hypertension means we are thinking that we are giving them 3 drugs, but patient may not be compliant with it. Patient may be skipping the medications, or patient may not be compliant with the dietary suggestions we would have given, or the salt restriction or the fluid restriction we would have given. That is the most common cause. So whenever we encounter resistant hypertension, we have to relook at the patient's dietary and compliance to the medications. Once that is clear that okay, patient is following the dietary restrictions as well as he's taking the medications properly, then we have to look at the other causes, right? What other things can cause? One of them is endocrine causes, the other one is renovascular. What are the endocrine causes which can cause resistant hypertension? Plenty of them. Hypo as well as hyperthyroidism, Cushing syndrome, pheochromocytoma and hyperaldosteronism. All of them can cause resistant hypertension. Sometimes there will be some additional clues in the question, right? For example, if you have pheochromocytoma, this typically causes what is called as episodic hypertension. Pheochromocytoma is often associated with, right, panic attacks. It is often associated with diaphoresis or profuse sweating, because in pheochromocytoma there is sudden release of catecholamines by these tumors, right? The adrenal medullary tumors. What catecholamines they are releasing? Adrenaline, noradrenaline or dopamine. So they cause vasoconstriction, shoot up the BP, but they also cause profuse sweating, right? Increase the heart rate. So that's why often patients report to hospital as panic attacks. Okay. Then renovascular hypertension can happen when you have a renal artery stenosis. So if the renal artery is constricted, then the blood flow to the kidney is reduced. So that leads to activation of RAS. So once the RAS gets activated, it gets too activated. Means your RAS blockade may not be sufficient to counter it. Until and unless you dilate the constricted blood vessel, you will not be able to get rid of it, right? Other than that, renal parenchymal disease means, for example, if I have CKD, that can also cause excess activation of the RAS. So these are all causes for the resistant hypertension, right? So what is the investigation of, yes, especially bilateral renal artery stenosis. Unilateral can cause, relatively less likely, but bilateral is very difficult to control BP. Okay. Now, what is the investigation of choice for the renal artery stenosis? Shubham Gai, absolutely right. What is the investigation of choice for renal artery stenosis? What is the initial investigation when you are suspecting the renal artery stenosis? The gold standard for any narrowed blood vessel is always going to be angiogram, right? Renal angiogram will be the gold standard, but the initial investigation is going to be renal vessel Doppler. Initial investigation, yeah, the Doppler is nothing but a form of USG. Okay, a few quick take on the hypertensive emergencies. Okay. So hypertensive emergencies in simple concept mean you have elevated blood pressure and acute hypertension mediated organ damage. Elevated blood pressure and acute hypertension mediated organ damage means what can be counted as an acute hypertension mediated organ damage? Acute heart failure, acute left ventricular failure, or sudden development of hypertensive encephalopathy, or development of stroke. Stroke can be ischemic as well as hemorrhagic, or sudden development of renal dysfunction, creatinine starting to go up suddenly, or development of oliguria all of a sudden, right? So these are all counted as acute hypertension mediated organ damage. So hypertensive emergency refers to increase in the blood pressure plus acute hypertension mediated organ damage. Okay. Then we come across two closely related terms, right? One of them is called as malignant hypertension. The other one is called as accelerated hypertension. Okay. So what are these two terms? Malignant hypertension refers to, malignant hypertension is nothing but one hypertensive emergency. It's not different from hypertensive emergencies, right? The basic concept is clear. BP is suddenly shooting up, causing acute hypertension mediated organ damage. Malignant hypertension is one type of hypertensive emergency where the acute hypertension mediated organ damage has mainly resulted in cerebral edema, resulting in papillary edema. So if you have a patient with suddenly BP shooting up to more than 200 by 120 and develops papillary edema, then we call it as malignant hypertension. Okay, then what is this accelerated hypertension? Accelerated hypertension refers to condition where the sudden rise in the BP leads to bleeding in the retina, retinal hemorrhages. We call it as accelerated hypertension. Nowadays it is not very important because we have replaced all these terminologies with one simple hypertensive emergency. There's another term called as hypertensive urgency, which means there is sudden rise in the BP but no acute hypertension mediated organ damage. Then we call it as urgency. Elevated BP but no acute hypertension mediated organ damage. When there is organ damage, it is hypertensive emergency. No longer we ask you what is malignant hypertension or accelerated hypertension. These terms are not very relevant today. But in the past we used to ask. If we get some old time examiner, he might ask. That's why we need to remember faintly. See, the accelerated hypertension, see, all these hypertensive emergencies, the diagnosis is not based on the BP cutoff. It is based on the organ damage, right? So if you have a hypertensive where the BP has increased from his usual baseline BP, most of the patients have their BP recording data from their previous files or medical records, so we know their baseline BP. From their baseline BP, now the BP has shot up, whatever degree, right? We don't have an absolute cutoff saying that 185, 110, that was all thing of the past. BP has risen, and now when I do the fundus examination, I see retinal hemorrhages, that is accelerated hypertension. Okay. BP has suddenly risen and I see papillary edema, that is malignant hypertension. BP has suddenly risen and patient has developed sudden onset heart failure with lung congestion, pulmonary edema, that is hypertensive emergency, right? BP has risen from his baseline value and now he is in altered sensorium and we are making a clinical diagnosis of hypertensive encephalopathy, that is hypertensive emergency. Okay. Now, how do we treat the hypertensive emergencies? So here a quick reduction in the blood pressure is required, right? We cannot slowly reduce the blood pressure. So for that reason, we use more injectable forms of blood pressure, but we also need the control on the rate of reduction of the blood pressure. So that is why we use those agents which can be given as an infusion. So we can use nitroglycerin, right? NTG or nitroprusside or labetalol. The sublingual route needs to be avoided. This is a very, very important point. Why we should avoid sublingual route? Because in that case, we do not have the control on the decrease in blood pressure. We can land up in hypotension also. Why? See, when we are giving infusion of labetalol, nitroprusside or nitroglycerin, if the BP starts dropping below the threshold we want, we can stop the infusion, right? Then BP will again start rising. But if I given a sublingual drug, the drug is all in the system. I don't have any control from outside, right? So if it is going to cause hypotension, it will. That is why we should avoid the sublingual route. Okay, so that is about the hypertension. One last topic that we will be now addressing is the arrhythmias. Okay. So from arrhythmias, what is important? Most likely it is the approach. We will take up the arrhythmias later. First we will complete the cardiomyopathies because we are talking about heart failure. Okay, what is cardiomyopathy? Cardiomyopathy are those disorders which ultimately presents to the clinic in the form of heart failure. Okay, but why are they developing heart failure? Because they have diseases which are affecting the cardiac muscle. That is why it is called as cardiomyopathies, muscle pathologies. But cardiac muscle can develop abnormalities when it has various other complications, like hypertension develops left ventricular hypertrophy. So if left ventricle is hypertrophied, it is a problem of the muscle. Can I call it as cardiomyopathy? No. If I have aortic stenosis, again left ventricle can develop hypertrophy because it is trying to eject the blood against this constricted aortic valve. So it will develop hypertrophy. Can I call it as cardiomyopathy? No, right? So how do we define cardiomyopathy? Cardiomyopathy is defined as a disorder of cardiac muscle due to non-vascular, non-valvular etiology. Non-vascular, non-valvular etiology. So when I say non-vascular, that means it rules out the hypertension. Hypertension is generally because of blood vessel constriction. And so in the absence of hypertension, your cardiac muscle has developed an abnormality. No valve is abnormal, right? This also ruled out ischemic heart disease because ischemic heart disease is also a disease of coronaries, blood vessels, right? And no aortic stenosis, mitral stenosis, pulmonic stenosis, no valvular pathology. So in the absence of a dysfunctional valve, in the absence of hypertension and ischemic heart disease, yet your cardiac muscle develops some abnormality, we call it as cardiomyopathy, right? How do we classify? We classify them into three groups: dilated cardiomyopathy, hypertrophic cardiomyopathy, and restrictive cardiomyopathy. What is dilated cardiomyopathy? Dilated cardiomyopathy is where your left ventricle becomes dilated, and when it becomes too dilated, it fails to generate sufficient force of contraction, and when it is not able to contract, that is what is our systolic heart failure. Technically, we call it as dilated cardiomyopathy when left ventricular end diastolic diameter is more than 6 centimeter. When it is more than 6 centimeters. Okay. Dilation of the left ventricle can happen because of ischemic heart disease. It can happen because of various other causes. But when in the absence of ischemic heart disease, hypertension and the valve problem, see, remember in aortic regurgitation and mitral regurgitation, left ventricle becomes dilated. That won't be called as the cardiomyopathy. It will be simply called as valvular heart disease with dilated left ventricle. In the absence of valve pathology, hypertension and IHD, when you develop dilation of the left ventricle, we call it as dilated cardiomyopathy. Technically, left ventricle should be larger than 6 centimeter at the end of diastole. Okay. So what all can cause this dilated cardiomyopathy? It can be caused by diabetes mellitus, alcohol. Alcohol is the most common toxin responsible for dilated cardiomyopathy. It can be caused by cocaine. It can be familial. The familial is generally due to mutation in a gene called as titin. Titin gene mutation leads to development of dilated cardiomyopathy, right? Apart from that, there are drugs like daunorubicin, doxorubicin, adriamycin. They can also cause dilated cardiomyopathy. So these are important causes. The list is quite long. Okay. So these patients develop systolic heart failure and we treat them like any other case of systolic heart failure. Means we start them on ACE inhibitors, ARBs, beta blockers, right? The same medication that we just discussed. Then we have this hypertrophic cardiomyopathy, right? Hypertrophic cardiomyopathy is not an acquired condition. If I have long-standing hypertension or if I have valvular disease and because of that my ventricle develops hypertrophy, it is just a valvular heart disease. Hypertrophic cardiomyopathy is an inherited disorder. Dilated cardiomyopathy can be caused by several causes. Inherited is also there, but it can also be caused by acquired causes. Hypertrophic cardiomyopathy is always inherited, right? It is the most common type of cardiomyopathy. This is a small controversial point. What is that? Though if you screen all the people on the earth, you will come to the conclusion that hypertrophic cardiomyopathy is the most common type of cardiomyopathy. Most of these patients are asymptomatic and not recognized. So among the recognized patients with cardiomyopathy, it is the dilated cardiomyopathy which is most common. So this is the most common symptomatic cardiomyopathy. Most common symptomatic cardiomyopathy. Okay. Apart from that, one more important point is the hypertrophic cardiomyopathy is the most common inherited cardiac disorder. Most common inherited cardiac disorder. Most common congenital heart disorder which leads to some clinical consequences is going to be VSD. Most common inherited valvular heart disease is bicuspid aortic valve, and most common overall inherited cardiac disorder is hypertrophic cardiomyopathy. It is seen in 1 in 500 births, and it is due to mutation in the beta myosin heavy chain gene. Beta myosin heavy chain gene. Beta myosin heavy chain gene. Okay. Then we have this restrictive cardiomyopathy, where the issue is something is restricting the dilatation of the ventricles during diastole. Generally, what restricts it? When the ventricles are loaded with abnormal substances, right? So in simple words, restrictive cardiomyopathy, all you need to remember is the storage disorders, like glycogen storage disorders, lipid storage disorders, they amyloidosis and hemochromatosis. They are classical examples. Okay. We will study a little bit more about hypertrophic cardiomyopathy. Before that, right, how do we treat dilated cardiomyopathy? Just like any patient with heart failure. How do we treat restrictive cardiomyopathy? We try to treat the underlying cause. If it is a treatable cause, like hemochromatosis is treatable by giving iron chelating agent and removal of the blood. If underlying cause is not treatable, then heart transplantation remains the only choice. Okay. Now getting back to the most important topic here, which is hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy. Right? So what problems it leads to? Without any increased workload on your ventricle, the ventricle starts developing, mainly the left ventricle start developing hypertrophy, right? So when left ventricle starts developing hypertrophy, it is not only the free wall of the left ventricle that develops the hypertrophy, but even the interventricular septum. And interventricular septum does not develop a uniform hypertrophy. It develops what we call as asymmetric septal hypertrophy, or ASH. What does that mean? Instead of becoming thick from end to end like this, right, it bulges inwards into the ventricular cavities, right? So we call that as asymmetric septal hypertrophy. What is the result of this? Because of this, first thing, left ventricular cavity size becomes smaller, and then second thing, if it is severe enough, it may obstruct the flow of blood from left ventricle to aorta, right? So this is where we have this aortic valve, right? This is the aorta. The blood from left ventricle may not be able to reach aorta easily because of this asymmetric septal hypertrophy. So when it becomes large enough to obstruct the flow of blood from LV to aorta, we call it as hypertrophic obstructive cardiomyopathy. So obstructive term will be added when it starts causing obstruction. And once it reaches the stage of obstruction, the ventricle shape starts looking like the shape of a banana. This is a repeatedly asked MCQ point, right? Where do we get this banana shaped left ventricle? That is in hypertrophic obstructive cardiomyopathy, right? Yes, as Shubham mentioned, this asymmetric septal hypertrophy is eating into the left ventricular outflow tract, right? So obstruction is not at the level of aortic valve, but just below that. This is where the obstruction is happening. So that is why this condition is also called as subvalvular aortic stenosis. Valve उसके नीचे के level पे obstruction है, so we call it as subvalvular aortic stenosis. But most of the patients who have hypertrophic cardiomyopathy do not reach this stage of developing the obstructive cardiomyopathy. They are generally asymptomatic. They have the mutation, their left ventricle has become hypertrophied, but no obstructive symptoms. They don't come to the hospital with any complaints. But then suddenly, while doing some physical exercise, running in the field, playing some games, they collapse and they can die. Why that happens? Because this hypertrophic left ventricle becomes prone for arrhythmias. They just need one stimulus to get into a ventricular tachycardia or ventricular fibrillation. And that stimulus comes from adrenaline. So during exercise or physical activities, adrenaline level rises. This adrenaline will stimulate this ventricle to generate VT or VF, and VT and VF can be fatal, right? So in terms of echocardiography, in these patients, we can see asymmetric septal hypertrophy, left ventricular hypertrophy, and apart from that, this anterior mitral leaflet, there are two leaflets to the mitral valve, right? The anterior leaflet, this one, right? This is attached to a papillary muscle resting on the interventricular septum. So when this interventricular septum, this is a hypertrophic septum, right? Muscular, gym guy. So when it contracts, it will pull this anterior mitral leaflets more towards itself. This is what we call as systolic anterior movement or anterior motion of anterior mitral leaflet, or SAM. systolic anterior motion of the anterior mitral leaflet. So that also adds to obstruction. On one hand, this is creating obstruction. Mitral leaflet coming here during systole creates further obstruction, making very less space available for the blood to move. Right? This can be seen on the echocardiography. Okay. Now, this is the most common cause for sudden cardiac death. In whom? In young individuals and athletes. Young individuals and athletes. So that also begs another question. What is the most common cause for sudden cardiac death? Overall, means all the patients, all age group, all professions put together. What is sudden cardiac death? Where patient dies with no pre-warning or forewarning symptoms. Okay, if I develop chest pain now and half an hour later I die, it is not sudden cardiac death. I'm talking to you and I collapse here and die without even me realizing that something is going on with me. That is sudden cardiac death. You might have heard stories, right? Dadaji सोने के लिए गए थे, सुबह उठे ही नहीं. So night somewhere he died. That is a sudden cardiac death. The most common cause for sudden cardiac death. The most common cause for sudden cardiac death overall is the ischemic heart disease, right? Massive MI, before you realize patients can die. Before they feel anything, they can die. So ischemic heart disease is the most common cause for sudden cardiac death overall. But in young individuals, we do not have ischemic heart disease yet, right? So in young individuals and athletes, it is the hypertrophic cardiomyopathy. The most common reason for that, yes, there is contribution of the fixed cardiac output, but that usually leads to syncope. See, if the cardiac output is reduced, my brain may not get sufficient blood supply when I am doing physical exertion, and I can develop a syncope. But as soon as I fall down, right, the venous return to the heart increases, and I may be able to get some blood supply to my brain, and I can come out of that syncope. So syncope is common when you have obstructive cardiomyopathy, but that may not contribute to death. Death typically happens because of the ventricular tachycardia or ventricular fibrillation, and this gets triggered by the exertion, because during exertion sympathetic nervous system activity increases, there is more adrenaline, and adrenaline becomes the stimulus for the generation of the ventricular tachycardia or ventricular fibrillation. Okay. Now, how do we treat a patient with the hypertrophic cardiomyopathy? Objective number one is to prevent ventricular tachycardia or ventricular fibrillation. So for that, we need to give them the instruction saying that avoid vigorous exertion. That is very, very important, because you go into vigorous exertion, adrenaline shoots up, you have VTVF and you can die. Second thing, adrenaline is the link between the sudden cardiac death, right, and the exertion. So I can block the adrenaline's effect by giving the beta blockers. So beta blockers become the drug of choice for the prevention of VT and VF. Okay, VT or VF. But if I start beta blockers and still patient goes on to experience a VT VF, then I cannot rely on the beta blockers, right? Patient may develop one VT or VF and then he may not recover from it. So in such cases, what we should do, if patient develops even a single episode of VT or VF while being on beta blockers, we should put them on implantable cardioverter defibrillator, so that if they develop a VT or VF, the implantable cardioverter defibrillator will shock instantaneously. Clear? Okay. Then if there is obstructive cardiomyopathy, where you have this fixed cardiac output and patient is experiencing repeated episodes of syncope, in such cases, how can we treat it, right? So in that case, we need to get rid of this obstruction. How can we get rid of this obstruction? You have two choices. You can surgically cut this portion. It is called as septal myomectomy. You can cut this portion. Or instead, you can inject the alcohol into the interventricular septum. That will make the septum get atrophied and relieve the obstruction. So today we generally follow more of alcoholic ablation, and we have replaced that alcohol in the very recent times with the laser burns infused on the interventricular septum. So we can either use alcohol or laser. If that is not feasible or there is massive obstruction, in that case you can do septal myomectomy. Septal myomectomy, surgically cut through the interventricular septum. Okay, that's it, right? Now DCM, we have understood the key points that we need to know. We will quickly get into the arrhythmias now. Okay. Now, almost every alternate exam they were giving one arrhythmia based question. FMGE में नहीं तो NEET PG में, NEET PG में नहीं तो FMGE में. But last 2 years the number of questions on the ECG has dipped down in NEET PG as well as FMGE. But this time I'm expecting one question. And if you ask me, sir, what is the favorite topic on ECG? It is not going to be those WPW syndrome and all. It is going to be straightforward, simple arrhythmias. Okay. So what we need to do is develop a quick approach to arrhythmias. So whenever they give a question where patient complaint is palpitations, right, or loss of consciousness, it should make you think that a possibility of arrhythmia is there in that question, and often they would have given an ECG. So when you see an ECG where you're thinking of a tachyarrhythmia, first thing to notice is the QRS complexes, whether the QRS complexes are narrow or wide, So what is the basis to decide whether they are narrow or wide? How do you decide whether the QRS complexes are narrow or wide? What is the normal QRS duration? The normal QRS duration is the normal QRS duration is 80 to 110 milliseconds or 100 milliseconds. So it is always less than 120 milliseconds. So anything more than 120 millisecond is increased, right? So if you have a tachyarrhythmia, what we need to do first thing is see the QRS complexes or QRS duration. If it is more than 120 milliseconds, that means we are dealing with a wide complex tachyarrhythmia. And if it is less than 120 milliseconds, that means we are dealing with a narrow complex tachyarrhythmia. Yes, all of you know this. 1 small square is equal to 40 milliseconds. So if the QRS is taking less than 3 small square, it is a narrow complex tachyarrhythmia. If it is taking more than 3 milliseconds, it is wide complex tachyarrhythmia. Okay. Now in narrow complex tachyarrhythmia, I need to understand whether the patient is having PSVT, whether he is having atrial fibrillation, or whether he is having atrial tachycardia. And there is one more differential diagnosis here, that is sinus tachycardia. So how to differentiate between these four? That's what we will learn first, and then we will go back to that ECG. So once we have a narrow complex tachycardia, we have to see whether P waves are present or absent. Okay, whether P waves are present or absent. If P waves are present, that means atria is getting depolarized, right? So only two possibilities are there if P waves are present. The first one is sinus tachycardia, and the second one is the atrial tachycardia, sinus tachycardia and atrial tachycardia. In both these conditions, you have narrow QRS complexes and P waves are present. Then how do I differentiate whether I have atrial tachycardia or sinus tachycardia? If SA node is the in charge of the rhythm, then the atria is getting depolarized by the wave started by SA node, and the ventricle is also getting depolarized by the wave started by the ventricle. So in that case, in any given ECG, the number of P waves will be equal to the number of QRS complexes, right? And every P will be followed by a QRS, right? Behind every QRS there will be a P wave. So if you find an ECG where heart rate is more than 100, that is tachycardia, and P is followed by QRS, followed by P, followed by QRS, this relationship is maintained, number of P waves is equal to number of QRS complexes, then it is sinus tachycardia. But when you say atrial tachycardia, means atrial rate is higher than the ventricular rate. So in atrial tachycardias, the number of P waves will be more than the QRS complexes. Number of P waves will be more than the QRS complexes. Clear? Okay. Now in atrial tachycardia, we have subtypes. One of the subtype is focal atrial tachycardia, where some focus in the atrium is becoming a pacemaker and starting the tachycardia. So in that case, you will have a same looking P waves. They won't ask you focal atrial tachycardia at the FMGE or NEET PG level. What they will ask you is two ECGs. One type of atrial tachycardia called as multifocal atrial tachycardia or MAT, and the other thing they will ask you is the atrial flutter. Okay. How do I identify multifocal atrial tachycardia? Look at the name of the disease. Multifocal means if this is the atria, right atrium and left atrium. Normally SA node was the pacemaker, but here something else has become pacemaker. To call it as multifocal, that means multiple foci have become pacemakers. So one time atria gets depolarized because of the impulse starting here, second times because of the impulse starting here, another time because of the impulse starting here. So all these P waves are not going to look same, right? So when impulse started here and then caused the depolarization of the atria, the P wave will look different. And if started here and then caused the depolarization of the atria, the P wave will look different. So in an ECG where you see multiple P waves more than the QRS complexes, and you can identify at least three morphologically different P waves, then it is a case of multifocal atrial tachycardia. In the exam, you may not get sufficient time to look for all these details, right? They will give you two clues to consider this as a case of multifocal atrial tachycardia. The first clue is that patient, they will mention that it is a case of COPD. And the second clue that they will mention is that there will be arrow marks pointing towards those different looking P waves. One P wave may be upright, one more may be inverted, one more may be tall and spiking. So when P waves look different, that is your multifocal atrial tachycardia. And then atrial flutter. Atrial flutter is where the atrial rate is much higher than the ventricular rate, giving rise to the baseline appearing like a sawtooth. So it is like P waves are more than QRS complexes, right? So this is all P waves. Then you will have one QRS complex, right? Again, many P waves. Then you will have one QRS complexes. So that makes the baseline look like what we call as sawtooth appearance. So whenever you see that, you know that you're dealing with a case of atrial flutter. We call it as atrial flutter. Why that is happening? Because it is an atrial tachycardia where atrial rate is way higher than the ventricular rate. So multiple P waves, few QRS complexes, giving rise to this sawtooth appearance. Now if I get a narrow complex tachyarrhythmia where the P waves are absent, if the P waves are absent, then what are my differential diagnosis? The atrial fibrillation and the PSVT, right? Those are the two differential diagnoses. What are my differential diagnoses? Atrial fibrillation and PSVT. How do we differentiate between these two? By looking at the RR interval. In atrial fibrillation, the RR interval is varying, it is not constant. In patients with PSVT, the RR interval is going to be constant. So that helps us to differentiate between atrial fibrillation and PSVT. This is our approach to narrow complex tachyarrhythmias. Okay, so let us quickly look at the image that we had just now and see whether that was a case of narrow complex tachyarrhythmia, and if it was a case of narrow complex tachyarrhythmia, what is it? So look at this ECG carefully, primarily focus on the rhythm strip or the bottom line, right? So when you look closely, what do you think is the QRS duration? This is where the Q wave is there, this is where the S wave ends, right? This is my QRS. Is it occupying more than 3 small squares or less than 3 small square? This is 5 small square. This is where roughly it will be 3. This is less than 3 small squares, right? So clearly it is a narrow complex tachyarrhythmia. This is a narrow complex tachyarrhythmia. With a narrow complex tachyarrhythmia and absent P waves. Narrow complex tachyarrhythmia with absent P waves. So we have only two differential diagnoses. This is not flutter. That's what I told. So to call it as the atrial tachycardia. Under atrial tachycardia, we have focal atrial tachycardia, multifocal atrial tachycardia, and atrial flutter. We should have more number of P waves than the QRS complexes. Okay. So this is a condition where you have absent P waves, narrow complex tachyarrhythmia. What are my differential diagnoses in that case? I know some of you may be thinking that, sir, my real trouble is to know whether the T waves and P waves, I get confused between them, whether there is a P wave or it is a T wave. I see something here, so should I consider it as a T wave or should I consider it as a P wave? Right? Clear? I know this doubt. See, the conditions where the T wave is not recognizable are rare. You can have slightly flattened T wave, inverted T waves, tall T wave, but absolutely non-discernible T waves are rare, especially rare in the context of tachyarrhythmias. So that is why when you get confused, I know there are different ways to identify it, but not for the exam going student. So simple hack is, when you get a rhythm strip, When you see other than QRS, some upright wave, right? Start labeling it as T wave, because the absent T waves is relatively rare. So if you label it as T wave, then look for, do I find anything else also to call as P wave? If I find anything else to call as P wave, then that means I have P waves. If I don't find anything, then take it like, okay, T waves are there, P waves are not there. So this is a condition where I don't find anything other than something which I am labeling as T waves. So I will take it as absent P waves. Narrow complex tachyarrhythmia with absent P waves. Two differential diagnoses, atrial fibrillation and PSVT. How to distinguish between the two? By looking at the RR interval, right? Whether they are constant or whether they are varying. Yes, Shubham, those are more precise ways. So I'm just giving a hack for the students who are just getting into the examination hall. Most of them may not have the strong foundation of ECGs. So here what do? We look at the RR interval. Is it varying or constant? From beat to beat it is constant. So then what should be our diagnosis here? It will become a case of PSVT, right? Then look at this bottom ECG. Look at this bottom ECG, right? What do you think this is? Narrow complex or wide complex? QRS, this is the QRS duration, right? Is it more than 3 small square? This is 5 small square, right? This is my QRS duration. Is it more than 3? No, right? Though this is a narrow complex tachyarrhythmia. Okay. Do I find anything to confidently say this is P wave? I know there are some baseline undulations. We call these baseline undulations as fibrillatory waves or F waves. Otherwise, I don't find anything properly countable as P wave. So again, I have narrow complex tachyarrhythmia with absent P waves. So whenever we have narrow complex tachyarrhythmia and absent P waves, atrial fibrillation and PSVT are two differential diagnoses. Look at the RR interval. Here the RR interval is significantly varying from one beat to next beat. So then the diagnosis becomes atrial fibrillation, right? Diagnosis becomes atrial fibrillation. So you have to always remember this approach. Arrhythmia, look at the QRS, more than 3 small square, wide complex tachyarrhythmia, less than 3 small square, narrow complex tachyarrhythmia, right? If it is narrow, look for the presence of P waves. And when I say P waves, it should be morphologically distinct P waves. Some baseline undulations or variations, don't take them as P waves. If I can see clearly something which can be called as P wave, that means P waves are present. If number of P waves and QRS complex are equal, a P is followed by QRS. Behind every QRS there is a P, that is sinus tachycardia. If P waves are more in number than the QRS, that is atrial tachycardia. Okay, and there if you find 3 different looking P waves in any lead, right, that means you have multifocal atrial tachycardia. And if too many P waves giving a sawtooth appearance, then you have atrial flutter. Okay, if absent P waves, take mainly the two important differential diagnoses, that is atrial fibrillation and PSVT. Differentiate between the two by looking at the RR interval. Varying hai to atrial fibrillation, constant hai to PSVT. Absolutely, Shubham. It's true. It's very true. Okay. Now, how about the wide complex tachyarrhythmias? Wide complex tachyarrhythmias is where the QRS is wide, right? They are very easy to identify. We generally do not get confused between those wide complex tachyarrhythmias. Again, those who are like ECG nerds, apart from the common wide complex tachyarrhythmias, you have a condition called as SVT with aberrancy. Means if QRS complex are already wide because of bundle branch block or various other reason, and on top of that a narrow complex tachyarrhythmia happens, the outcome is wide complex tachycardia, right? So differentiation between SVT with aberrancy versus your conventional wide complex tachyarrhythmias is a INI CT or the NEET SS topic. I'm not getting into it. We will just stick to what is basically important for us. Okay, so let me see if I have an image of any wide complex tachyarrhythmia. Okay, so here we have. So when it comes to wide complex tachyarrhythmias, we have 3 wide complex tachyarrhythmias to remember. One is monomorphic VT, where you have wide QRS complexes. You might have seen this image in previous sessions also. You have wide QRS complexes, right? So when you see these QRS complexes, they are taking almost 3.5 to 4 large squares, 4 small squares, right? So that is a wide complex tachyarrhythmia. In such case, take any one lead, and if all the QRSs look same, right? Here they all look same. In V4 they all look same. Take any other lead, V5 they all look same, right? Take any other lead, V2 they all look same. So if they all look same morphologically in a given lead, then it will be called as monomorphic VT, right? If they look different, QRS complex are wide, but they look different, then it will be either a polymorphic VT or ventricular fibrillation. Polymorphic VT or ventricular fibrillation. Then how do we differentiate between polymorphic VT and ventricular fibrillation? Mainly look at the QRS amplitude. Normal QRS amplitude in the chest lead will generally occupy close to 2 large squares. So if it is occupying less than 1 large square, that means the amplitude is significantly reduced. So if you take any lead, QRS morphology is looking different, right? This complex is different from this, it is different from this, it is different from that. So the QRS amplitude is like the morphology is differing within a lead, they are not same, and amplitude is small, then it is ventricular fibrillation. If the same ECG but the amplitude is relatively larger, then it is polymorphic ventricular tachycardia. So these are the 3 differential diagnoses whenever we have the wide complex tachyarrhythmias. Looking same in a lead, monomorphic VT, right? Looking different, but amplitude is normal, then it is polymorphic VT. Ventricular fibrillation is where they look different, but the amplitude is significantly small. Amplitude will be very small, then it is ventricular fibrillation. If you have a classical Torsades de Pointes and the patient is stable, yes, definitely you can give the magnesium sulfate, and if it helps you to recover the rhythm, then you know that this was Torsades de Pointes. But ventricular fibrillation is generally no confusion. The simple reason why this is no confusion is when you develop ventricular fibrillation, almost always the patient will be pulseless. Polymorphic VT, Torsades de Pointes, you can still present with pulse. Monomorphic VT, you can still present to hospital having an intact pulse. Ventricular fibrillation is almost always pulseless, because when we say ventricular fibrillation, that means ventricle is not contracting, merely shaking or vibrating. When it does not contract, there is no ejection. If there is no ejection, nothing is coming to your aorta, nothing is coming to your carotid. So most of your pulses will be abolished, right? Now, how do we manage these arrhythmias? I will just give you some 2-3 important rules. Rule number 1, any arrhythmia, if it is hemodynamically unstable, that means BP less than 90/60. BP less than 90/60. Within a polymorphic VT, whether you want to know whether it is TDP or not, yes, you can follow. But otherwise, again, TDP is also very easy to recognize, where you can have this in TDP. You can clearly have this twisting around of the QRS complexes around the axis, giving rise to a wavy pattern. Okay. Now, any patient with tachyarrhythmia, rule number 1 is look at the hemodynamic stability, that is BP. BP less than 90/60. Only way to treat is shock. More than 90/60, pharmacotherapy and other conventional measures. Clear? So less than 90/60, we need to give shock, right? What kind of shock to be given is again an important question. What kind of shock? There are 2 types, right? Cardioversion and defibrillation. So I will just tell you one important point here. We follow cardioversion. Defibrillation is for only 2 arrhythmias. What are those 2 arrhythmias? One of them is ventricular fibrillation, regardless of the status. Ventricular fibrillation, defibrillate, because almost always it will be pulseless. The second one is ventricular tachycardia without pulse. For all other arrhythmias, means PSVT, atrial fibrillation, right? Ventricular tachycardia with pulse or any other tachyarrhythmia, if you need to give shock, it will be cardioversion. Yes, the difference between cardioversion and defibrillation is, in cardioversion, the electrical shock is synchronized to the R wave. In defibrillation, we don't synchronize, just shock. Whether it falls on the QRS complexes, whether it falls on the P wave, whether the shock falls on the T wave, does not matter. Okay, that is step number 1. So any arrhythmia, this rule applies to any arrhythmia. First thing is to look at the BP, right? Any tachyarrhythmia, to be more precise. If BP is less than 90/60, we have to go for shock. And if BP is more than 90/60, then you can think of pharmacotherapy. And for arrhythmias like the PSVT, you have one pre-step before you give the drug, that is vagal maneuvers. So if you have PSVT, you can go for vagal maneuver. That includes carotid sinus massage, Valsalva or modified Valsalva. They all activate vagus nerve. By activating the vagus nerve, they can slow down the heart rate. If that helps, well and good. If that does not help, then again you have to come to pharmacotherapy, right? So 2 points before we close down today's session. The first point is, what is the drug of choice for PSVT, and what is the first step in the management of a stable PSVT. Then the third point is, what is the drug of choice for Torsades de Pointes, which I think you have already answered. I will write down those points and share it in the notes. Yes, the drug of choice for the PSVT is adenosine. If adenosine is contraindicated, the calcium channel blockers like verapamil or diltiazem can be used. The drug of choice for most other arrhythmias as of now is going to be amiodarone. Okay. And the drug of choice for Torsades de Pointes is magnesium sulfate. Okay. All these MCQ points will be shared to you in the written down notes. And that's it for today. In the next series, we will be starting with the MCQ based discussions, primarily focused on extremely high yield topics, scores and all. We will only be spending 10-15 minutes on a daily basis in the run up to the FMGE exam. And others who are interested, who are not giving FMGE exam, also can join. I think the team will share the schedule tomorrow, right? So that's it for today, guys. We will be again connecting at 8 o'clock. Those who are not for the FMGE, you can join me for this Harrison based series on the Synco. Those who are preparing for FMG, just get back to your basic sources from where you have already prepared and continue your preparation. See you soon, guys. Bye-bye.